Good morning. My name is Julie Kalkbrenner. I'm one of the Lurie Children's Physician Liaisons in the Western Suburbs. Thank you for joining us today as we introduce the Lurie Children's Division of Otolaryngology Head and Neck Surgery team. For this session, I will be introducing you to Dr. James Schroeder. He will just be discussing dysphagia management and FEES in children. A few quick notes, though, about ENT before we get started. Our patient care helps save and transform the children's lives. We provide medical and surgical treatment for children of disorders of the ear, nose, and throat, as well as head and neck tumors. Our physicians treat more children for ENT conditions than any other hospital in Illinois. In fact, our specialists perform approximately 40% of the nearly 20,000 surgeries that take place at Lurie Children's each year. We have a same-day ear tube procedure program that is available at both the main campus and at Lurie Children's in Westchester. This program allows patients to be evaluated and have their procedure done all on the same day. We are one of a few pediatric hospitals in the U.S. that offers same-day appointments for minor surgical procedures. A multidisciplinary team of experienced healthcare providers will care for your child and help create a plan. This team approach makes it easier for you to see every specialist your child needs under one roof and often in the same visit. The team treats patients downtown at Lurie, including Lincoln Park, Lake Forest, New Lenox, Northbrook, and Westchester. Lurie Children's is also a research center, which lets us provide access to innovative treatments that are available only at a limited number of centers throughout the country. Those studies are in patients with clinical trials. Our physicians train the next generation of specialists in pediatric ENT. Through our partnership with Northwestern University Feinberg School of Medicine, we offer a one-year otolaryngology fellowship program, which is headed by Dr. Schroeder. One last thing, I would like to remind you of Lurie MD, which is a new physician-to-physician call line, 1-855 Lurie MD, and this is dedicated to physicians in which you can call and request for a Lurie specialist and get general recommendations about patient care or next steps with any patient care. This phone line is available 24/7, and you have the option of either getting in touch with the specialist within 30 minutes or by the end of the business day. Now I have a few things I'd like to tell you about Dr. Schroeder. He is one of our he's the Vice Chair of Surgery at Ann and Robert H. Lurie Children's Hospital of Chicago, and he holds a dual academic appointment as Associate Professor in the Department of Otolaryngology Head and Neck Surgery and the Department of Medical Education at the Feinberg School of Medicine at Northwestern. He has held multiple leadership roles in both graduate and undergraduate medical education at Feinberg, including co-course director for problem-based learning, and currently is the Director of Fellowship Accreditation at McGaw. He is currently the Vice Chair for Education and the Department of Surgery and the Program Director for the Pediatric Otolaryngology Fellowship Program at Lurie. He has been inducted into the Feinberg Academy Medical Educators Honor Society. He received the degree of Doctor of Medicine from Loyola University in Chicago and completed a residency in otolaryngology head and neck surgery at Rush, a fellowship in pediatric otolaryngology at Northwestern, and an education fellowship at the Searle Center for Advanced Learning and Training at Northwestern. He also has an MBA focused on healthcare administration and leadership. Dr. Schroeder sees patients at our main hospital at Lincoln Park in Westchester. He treats patients with airway and sinus problems and performs related surgeries. His research interests include pediatric obstructive sleep apnea and feeding problems in children, specifically related to congenital and acquired airway disorders. He has published over 70 scientific articles and book chapters and frequently lectures nationally and internationally on related topics. He is a member of and has held leadership roles in the American Academy of Otolaryngology Head and Neck Surgery, the American Bronchoesophageal Association, American Society of Pediatric Otolaryngology, American College of Surgeons, and others. He is the past president of the Chicago Laryngological and Otological Society. We encourage you to ask questions on the question bar on the side of your screen. Now I'm going to let you see Dr. Schroeder. I'm going to make him the presenter right now. Thank you.
Julie, thank you very much for that very generous introduction. And good morning, everyone. It's really a privilege to be here with you today and an honor to be asked to join this group of my colleagues. It looks like you have a really interesting and exciting agenda for the rest of the day and some really excellent ENT-related topics. I am very excited to have the opportunity to talk to you specifically about pediatric dysphagia. It's an area of interest of mine, and I look forward to exploring that with you for the next half hour or so. So in general, before we talk about the abnormal, it's important, I think, to review just some of the normal aspects of infant swallowing. And we'll talk specifically about what we'll call instrumental evaluations of swallowing. We'll define that and we'll compare and contrast what those are to better understand what their specific utility is going to be when managing patients who have dysphagia or difficulty with safely swallowing. The swallowing function or the swallowing process is in general taken for granted, right? It's something that just happens naturally. A newborn baby will very quickly root or suckle onto the breast or take a bottle. So we take for granted how this complex process just sort of works, right? Without going through getting too deep into the weeds, in general, it involves precise coordination with 4 cranial nerves, at least 26 muscles, and a very complex neuromuscular reflex called the laryngeal adductor reflex, which involves the superior laryngeal nerve, the nodose ganglion, the nucleus solitarius, the nucleus ambiguus, and the recurrent laryngeal nerve. And all of these processes need to work well very quickly in order for an infant to gain weight and to thrive. In adults, in general, this process is relatively static. In adults, you can have impacts on swallowing from things like stroke or cancer or surgery. But in children, we have to consider a whole nother process. When we're talking about swallowing in general, we need to understand phases of swallowing. And in newborn infants, which is, and young children, which is where we'll focus today, the preparatory and oral phase tend to go together. But in general, preparatory is, you can have the sound of making the bottle, crying, the rooting towards the breast, all getting and making saliva, all getting ready to swallow. We have the oral phase where that bolus, whatever it is, whether it's formula or food, moving from the lips back to the posterior pharyngeal wall. The pharyngeal portion, which is a very dynamic process where the palate elevates, the larynx elevates, and that bolus moves safely past the inlet of the oral cavity, safely protecting the lungs and moving into the esophagus. Then the cricopharyngeal muscle opens, which is the upper esophageal sphincter, and the bolus enters into the esophagus for peristalsis. We're not going to talk a lot about the esophageal phase today. It's fascinating. There's a lot of room for pathology there, but we'll save that for another time. The difference primarily when we're thinking about pediatric dysphagia is this process of evolution that occurs over the first 18 months of life or so. So a newborn baby, the way they take in nutrition, the way they suckle at the breast or the nipple is very different as the first few months of life progress. All of you know this very well as you're working with new parents as they're struggling with, they can struggle with breastfeeding or bottle feeding, and that transition of what that looks like over the first few months of life. This sort of relatively uncoordinated chomping movement can quickly transition or move into a more structured, mature sucking sometimes by 2, but at least by 4 to 6 months, where we're getting this suck, swallow, breathe coordinated process. We're increasing the volume of feedings from an ounce or 2 to 3 to 4 ounces every feed. The feeds are starting to move across a little bit as that volume of oral intake increases. This sort of transitions as we get into 7 to 9 months as the bolus changes now into sort of spoon feeding, and from sort of sucking the food off of the spoon into really moving that bolus around the mouth. Some of this for pleasure initially, and some of it's for function, particularly as we're moving into things like breakaway solids or chewable foods, or from dissolvable foods that the children will be placing in their mouth. Now, this whole process is occurring in conjunction with significant changes in anatomy. So this whole concept of form following function, right? Newborn babies, they're born with these adorable big fat cheeks, but they're really helpful. They help limit the size of the oral cavity. They have a relatively small mandible. That small mandible increases the relative size of the tongue in the mouth so that the bolus has nowhere to go. It can't go to the sides, it can't go up or down. It moves straight back along a relatively straight palate as it then enters into the pharynx, where the larynx is sitting really high. So if you look in a newborn's mouth, you've all seen this, the child cries, you can see the epiglottis staring right up at you like a little wall, or you place a tongue blade in the mouth, you can see that epiglottis. That allows the bolus to come back and contact that wall, essentially, get directed laterally around into the lower portions of the pharynx and gently moved into the esophagus and protecting the airway. So over time, over the first several months into the first several years of life, the anatomy changes to help support those functional changes we were discussing previously. So the larynx descends, so it moves from up around cervical spine, C2 or so, down to C6. Those buccal fat pads thin out. The mandible grows, the relative size of the tongue decreases in the mouth. So now we have opportunity to move that bolus side to side in the mouth. The bolus can be manipulated back into the pharynx differently. Now this becomes really important because often we'll see young children who are doing okay, feeding fine for the first several months of life, but then started to have difficulty and signs and symptoms that they're developing dysphagia, wet breathing, coughing, choking, or respiratory illness. What we need to be thinking about in this group, and the reason why this becomes so fascinating, is we have to think, is this a progressive issue, a neurologic problem that is developing and worsening? Or is it that as the child is growing and anatomically changing, are they losing that anatomical benefit that their anatomy provided in the newborn period? And now we're unmasking an already present neurologic issue or anatomical problem that was otherwise protected from some anatomical advantage. For example, breakaway solids, as the larynx descends, the time you need to get through that phase 3 or the pharyngeal phase of the swallow increases. So if you don't have the neurologic ability to control or adjust to that change in timing, you now have a child who may have been feeding or swallowing just fine, but now they're not able to compensate as well. So that's what makes the workup of children with dysphagia so much more interesting, because we have to compensate for these anatomical and developmental challenges as we're considering how to manage them. So why talk about this at all, right? There's so many more exciting topics I think that you guys are going to be experiencing throughout the day. But for me, this is really interesting for a few reasons. One, it's fairly common. So even in normally developed children, there's a high incidence of some episodes of dysphagia throughout their lifetime or throughout their infancy and childhood. And it often goes underdiagnosed. It's certainly much higher in children who have other developmental, particularly cardiovascular or neurologic disorders. And we know that also that the incidence is increasing. So it's relatively common, and it's also increasing, particularly with the rate of, as the rate of premature infants who survive into childhood and adulthood significantly increases. We know this group in particular is much more common, much more likely to have dysphagia, and up to 30% of children with cerebral palsy also have dysphagia. And to add to this complexity that we've been leading up to, almost 50% of children who have some episode of dysphagia have multiple causes of this, right? So it adds to the complexity of this workup. The etiology is can be multifactorial and in a number of different organ systems. The real point of this slide is, and we have great cases in each of these categories, which we won't have time to go through today, but the point of this slide is not to say that children who have signs of dysphagia need an exhaustive workup that includes MRIs and echocardiograms and multiple labs, et cetera, et cetera. It's just to know that the differential is fairly long, and we need to direct our workup specifically based on the presenting signs and symptoms in our children. who have some of these issues. There are often times where we'll have kids, particularly in the cardio respiratory category, that may have RSV and they were doing fine prior to that illness, and then develop signs and symptoms of dysphagia after. Our research, and this is similar to research in other institutions, children with RSV alone can have at least some element of dysphagia for 6 to 8 weeks after the injury, where they may need a temporary thickening of some of their, depending on their age, of some of their oral intake just to compensate, and this tends to resolve over time. So just understanding those common etiologies can really help us manage these children. Because of this, this is often a collaborative event that is, we use multiple input from multiple specialties. We have our FEES dysphagia clinic every Friday. We brought this to Lurie Children's a number of years ago, about 10 or 12 years ago. It was the first FEES multidisciplinary pediatric multidisciplinary clinic in the area, and we use input from all these different specialists, particularly from the primary care provider, whether pediatrician, family practitioner, et cetera. The use of Care Everywhere has been really helpful over the last 5 years or so, as we get a better understanding of exactly the concerns of the primary care provider, as well as collaborating with them after the exam for continued workup, and often we need continued engagement to help manage the children as we move forward with treatment. Because the differential is so long, we have we're really fortunate to have a large toolbox of opportunities to help target our approach when we're considering a workup. For the point of today's discussion, we're going to focus on 2 exams that we'll call the instrumental evaluation of swallowing. We're going to focus on the swallow study, often called the barium swallow, a cookie swallow, videofluoroscopic swallow study. Depending on your institution, it goes by a number of names. And the fiber optic endoscopic evaluation of swallowing, or the FEES exam. Both of these use instruments to help assess the swallowing function in a child. They're not mutually exclusive. They both provide information. They don't necessarily need to be used together, but it's really helpful to understand what they are so we can target their approach. We'll talk first about videofluoroscopic swallow study. I would imagine most of the people in this conference have ordered, reviewed, or evaluated these types of studies. They have a lot of advantages. They view all phases of swallowing. They allow the therapist, who's usually performing the exam with the radiologist, to try what we call compensatory strategies. These could be thickening the liquids, changing flow through nipple size, etc., using external supports or positional changes to help improve the swallow, the safety of the swallow, etc. It involves, we can see structure, so we know sort of what phase of swallowing we're evaluating. There's some disadvantages. There is a radiation exposure, and this can be significant. There's some academic debate about whether it's appropriate to use 15 frames a second or 30 frames a second, et cetera, which significantly changes radiation exposure, but also reduces the fidelity of the exam, if you will. It's not appropriate for a primarily breastfed infant. We're going to talk a little bit more about breastfeeding in a few minutes. And it's not appropriate for a child who has oral aversion or takes no oral intake, right? If they're not going to voluntarily take something through the mouth, this exam is really not the most appropriate exam. So here's an example. Again, many of you have seen these. We've made sure that swallow exams, at least snippets like this, are available when the exams are done at Lurie in Care Everywhere and in EPIC, so you can review these yourself. Here you're seeing a child, this is a 5-year-old who was formerly orally averse and had multiple different medical problems, wasn't taking food by mouth, was G-tube fed, but was now starting to take some by mouth, and the therapist wanted to make sure that it was safe to do so. And if you see in this exam anterior, not sure if you can see my pointer, but we have the esophagus back here, and right here is the trachea, and you can see that as they're swallowing, some of that bolus goes right through the vocal cords and down into the trachea. So this child is not safe for what was happening here. So the exam was successful in helping the therapist figure out where to move next. When we consider a FEES exam, I think in general this exam is a bit more, practitioners are perhaps a bit less comfortable with this exam. It's been around for a while. It's first described in adults in the 1990s in Boston and Chicago. It allows us to directly view the anatomy, the critical structures of the pharynx and larynx, so we can understand how safe the swallow actually is, and make a treatment plan based on what we're seeing. I'm often asked by practitioners and parents about the safety or the efficacy of the exam. So in general, when we compare video swallow to fluoroscopic, a video swallow to a FEES exam, there's high agreement between sensitivity, specificity, negative and positive predictive values. When we're looking at penetration, or the bolus coming to the vocal cords but not quite going through, and aspiration, which is what we saw on the previous slide, where the bolus comes through the vocal cords and enters the trachea, there's a near perfect agreement between both exams depending on the studies you look at. In addition, we know that inter-observer reliability, right, because both exams depend somewhat on the interpretation of the exam provider, so whether it's a therapist, a radiologist, or otolaryngologist, the higher inter-observer agreement occurs with the FEES exam. So at least academically, both exams are similar when it comes to providing useful information for our patients. So when we consider specifically the FEES exam, one of the advantages here is that we're able to evaluate secretion management. So if we're worried about a patient who is having significant oral secretions and whether or not they're aspirating those oral secretions, the FEES exam is the preferred exam. You can't just put a drop of barium in a child's mouth and then get a full assessment of how that barium will be processed in the pharynx and whether or not they're aspirating their oral secretions. So it really helps us identify if this child is able to protect their airway. We're able to evaluate sensory function of the larynx as part of this. There's no barium, no radiation, so consistent with the American Academy of Pediatrics and the American Academy of Radiology recommendations to reduce the amount of radiation that we provide to some of these vulnerable children. This is consistent with those directives. We can move the exam to the bedside, whether it's a hospitalized patient or somebody in the NICU with a PICU, and we're able to evaluate breastfeeding, which again, I'll come back to. It does require some special training. We had to send our staff for several courses to enable them to adequately label and perform the exams. Some children have some discomfort in the exam. In general, all of our published studies on newborns, infants, breastfeeding infants, the less than 2% of the time will there be the child will not tolerate the exam to get reasonable information. I will say that children, 2-year-olds in general, do not respond well to this exam. Younger than that, we can work with some reward to get through the exam. Newborn babies do fine. And over the age of 3 or 3.5, we have sort of videos and movies, and again, some helpful reward to help get the children through. But a 2-year-old is in general not the ideal candidate for a FEES exam. Here's an example of a FEES exam. We have a video swallow done on the same patient the same day. We normally do not do video swallow and FEES exam on the same patient the same day. This is just for academic purposes and presentation. But we can see the child, if you look at the video swallow, there's a portion of the bolus is entering into the larynx here. So if we look at this live swallow, this is the actual FEES exam footage. We can see the green bolus coming through. And as the bolus comes through, we're going to notice that there is the dyed green formula. We see it right there, enters the larynx right at the center. So this was really helpful. One, we can confirm there's penetration through the video swallow, and we know where the penetration is happening through the FEES exam. So this leads us to it's an uncommon diagnosis, but fairly common in our patient population, this idea of a laryngeal cleft. There are 5 types. The type 1 cleft, which brings this sort of narrow cleft down towards the level of the vocal cords, is the most common. The patient I just presented to you had a cleft. The top part of the screen is the anterior larynx. The bottom part of the screen is where the esophagus would be, and this is a probe in that cleft. You can see it's low down to the vocal cords. Another picture of the probe. The surgical intervention, we use a laser to make a small little mucosal diamond-shaped incision, and then we suture that up with a very fine suture to bring this posterior wall higher, so that if we repeat both the video swallow and the FEES exam, you can see now that the penetration has gone away, the bolus falls back into the bottom of the pharynx, collects right above the esophagus, right there, and then it gets entered into the esophagus without spilling into the larynx, which is what we're looking to see. To change gear in a different type of patients, we've all managed and seen children who have congenital laryngomalacia, the most common cause of noisy breathing in an infant. I have turned off the sound here, but you can imagine a loud inspiratory stridor. This patient has significant laryngomalacia with tracheal tugging. You can see the laryngeal view here, where we're getting significant collapse of that supraglottic, the area above the vocal cords. That epiglottis is squished into a little ball, making it very difficult for this child to breathe. So this is not a talk about laryngomalacia. However, there are multiple factors used to define the severity of laryngomalacia between mild, moderate, and severe. Very few children will have severe, but we use the easiest thing is not to worry about all these categories here, but to think about whether or not the laryngomalacia is just simple high-pitched noisy breathing, or is it high-pitched noisy breathing worsening with feeding and often associated with that wet laryngeal sound or that wet breathing sound after feeding. So in essence, there's a component of dysphagia associated with it. And that component of dysphagia brings it up into that moderate category, which would provide the opportunity for different types of treatment for these children. In particular, you can see that as the severity of the laryngomalacia changes, so that mild category where most children are just a high-pitched noisy breathing that bothers the parents more than the child, very few of them have any dysphagia with aspiration. But as we get higher into the moderate or severe category, the number of children who have dysphagia with aspiration significantly increases. So this sort of begs the question, what do we do with these patients? For me, and in our practice at Lurie Children's, many of these children come in for a FEES exam because one, it confirms the laryngomalacia, and then two, it allows us to determine what compensatory strategies we need to enact to help keep the children feeding normally. This is what we would do in the severe case. It's a supraglottoplasty. We trim a portion of the supraglottis to open that larynx up beautifully. The supraglottoplasty, we've been able to demonstrate, not only improves the airway, it significantly improves the dysphagia, right? So children are much more likely to have a resolution of not only obstruction, but of the dysphagia in these groups. The outliers are the children who have underlying neurologic or cardiac conditions. They're less likely to have resolution of both obstruction and dysphagia, but that luckily is a smaller group. When we consider breastfeeding as an issue, the American Academy of Pediatrics recommends continued breastfeeding in children up to at least 6 months. So does the World Health Organization. The percentage of children who are breastfed in general is significantly increasing. And we know that children who have signs and symptoms of breastfeeding difficulty, coughing, choking, or wet sounding, noisy breathing, are often much more likely to wean way too early. So we want to really be cognizant of how to manage these children. There are multiple ways we assess these children, but we wanted to think about if they needed to have an assessment, how do we do that, right? Can we use a barium video swallow? Often we find that video swallows are ordered on these children, but if you're primarily breastfed, obviously we can't get barium into the breast, but is it appropriate to just give this child a bottle, or can we utilize the FEES exam in these children? The literature is clear on this, that the anatomy, physiology, and actual function of swallowing in a breastfed infant is different than a bottle-fed infant. So merely just giving a breastfed infant a bottle with barium in it isn't an appropriate way to evaluate whether or not they're having a true dysphagia. What we've been doing in this patient population, and we've published several of the largest studies on breastfeeding infants who have signs of dysphagia, is we use the FEES exam. We place a little bit of commercially available food dye into the baby's mouth with a little sponge, and then we place the patient to the mother's breast. She lets us know if she can when she's feeling her letdown, and then we do the exam. And we're able to very clearly, here we see the green dye is staining most of the pharynx, but the larynx stays pink because it's protected. Once the mother starts with her milk letdown, we'll see a little bit of breast milk coming down. And then as the suck, swallow, breathe sequence begins, we're going to see that milk clearly passing past the larynx down into the esophageal inlet, clearly away from the breast. So here was a child with laryngomalacia, signs and symptoms of dysphagia, but through the FEES exam, we're able to demonstrate that breastfeeding can continue because the child was doing well. So in general with breastfeeding, FEES exam is a very safe way to evaluate primarily breastfed infants who have signs and symptoms of dysphagia with or without noisy breathing. It's really effective and should be the preferred methodology used in these children. Children were much more likely to maintain breastfeeding, which is our goal when the parent desires that we continue that. We're much more likely to do that. Our recent study demonstrate of the 20 or so children sent in who are primarily breastfed and told not to breastfeed because of worries about aspiration, we were able to maintain breastfeeding in 17 of those, which is a really high rate. So it's a really excellent and very safe, well-tolerated exam. In summary, in general, we want to think about the normal swallow as a really complex sequence of events. And we want to consider that sort of normal maturational development, anatomical development, particularly during those first 12 to 18 months of life. We know that dysphagia is very common. It's something we need to think about in our patients and to look for and consider when we have certain signs and symptoms that are presenting. Consider the multidisciplinary approach. Our group is here and ready and available to consult and assist you with the managing of patients. Think about what type of exam you may want to consider, particularly when we're considering an assessment, thinking about the FEES exam versus the video swallow. Both of them are very helpful, very useful, but they have different, they're more suited for particular situations. So in general, I think that's it. I think that was my 20 minutes. I'm not sure, Julie, if you want us to answer some questions. I'd be happy to do so if we have the time.
Sure. Thank you, Dr. Schroeder. That was excellent information and a very thorough comparison of the different types of studies available. Speaking of the studies, I do have a question. How do you recommend that the pediatrician make that determination as far as what type of swallow study to order, or is that something that you prefer to do as a specialist at the clinic visit?
Either is fine. So if you call the 1-800-KIDS doc and you have a patient with dysphagia, the KIDS doc representative will help you. We have a decision tree set up so that they will help you determine whether they should be referred for video swallow or FEES. That queue is also evaluated by our speech pathologists who help run the FEES clinic every Friday. So we'll help support that. You could use the app, the children's app, where you can contact us directly and we'll help you respond to that specific question. I can always, if they're on Epic, I often will review the chart and let you know very clearly if we should send them right to the FEES clinic on Friday or get a video swallow first. Any of those opportunities are fine.
Okay, very good, thank you. And then I have one other question. When a patient is sent in with a diagnosis of dysphagia, when does ENT get involved with the assessment?
Well, so it depends how they're coming to us. So if they're coming through the work queue, so we have a specific dysphagia work queue through 1-800-KIDS doc. When that comes through, our nursing team will evaluate those patients and then put them either through into my clinic or initially into the speech pathology queue to get them a clinical assessment there. If they're coming through the hospital, they're often if they're an inpatient or in the NICU, then the otolaryngology service is consulted and will collaborate with the speech and language pathologist.
Okay, very good. All right, well, thank you very much. You certainly packed our 30-minute discussion there. One last thing for all the attendees is we do have a handout in the handout section on the right-hand side that lists all of the ENT providers at Lurie and which locations they see patients. So thank you very much, Dr. Schroeder, for your excellent information today. And I want to thank the audience for their questions and participation in the lecture. We appreciate all the information and we appreciate all the attendance as well. So please feel free to join us for the other 3 lectures we have today with Dr. Young, Dr. Ida, and Dr. Billings. So enjoy the afternoon and thanks again, Dr. Schroeder.
Thank you so much.
Hey, Julie, when you do the slides, you have to put it in